When we come to assess the elbow, there's a number of factors that we need to consider. First of all, the anatomy of the elbow makes it inherently a stable structure. Injuries that we do identify at the elbow are either single event macro trauma, so these are the acute injuries where something has suddenly been overloaded and it fails. We can get single event trauma on vulnerable tissue, so for example you might have somebody who's got a degraded common extensor origin, and they go off and they play tennis in the wet, and they hit a heavy wet ball, and that suddenly causes failure of the common extensor origin. Or it can be, which is very common, a multiple repetition overuse injury. So things like tennis elbow, golfer's elbow, they're the common types of injuries that we see. The most common injuries that are identified at the elbow are overuse syndromes. Whenever we do see traumatic injuries, a large proportion of these are associated with fractures of either the olecranon or the lower end of the humerus. When we assess the elbow, it follows a similar structure to any other joints. So we look at observation, range of movement, muscle strength and length tests, and then a series of special tests. But one of the things that's very important to do is, because of the intimate relationships, the intimate anatomical relationship of the elbow and the superior radioulnar joint, both joints must be checked. In addition to that, it's not uncommon to have shoulder pathologies that can refer down to the elbow, and also wrist pathologies that can impact on elbow function and activity. The cervicothoracic spine may also create a neurological referral down there, so it's important to check that too. The subjective assessment, again follows a similar format to any other subjective assessment. It's essential that a clear description of the mechanism of injury and current aggravating factors are identified. Seek to ask the individual if there are any relationships between cervicothoracic posture and or cervicothoracic movement and their elbow pain. So for example, does their tennis elbow pain come on when they've been sitting at the computer for a long period of time, for example? Typically, there are red flags to look out for: any history of recent falls, trauma to the head and neck, unexplained weight loss, fever, diabetes, cancer. Chronic steroid use is very important around the elbow, including people who've had repetitive hydrocortisone injections into the region. Evidence of spinal cord compression, so bilateral symptoms, and severe weakness and atrophy of the hand musculature in particular, or other neurological disturbances, loss of pain, temperature, sensation, gait disturbances, or positive Babinski sign. The objective assessment again follows a similar pattern to any other. You start off observing posture, in particular the elbow, hand, and shoulder and cervicothoracic posture. Look at ranges of movement. Look at any accessory movements that may be indicated, any muscle tests, and then you go on to your special tests, finishing up with either functional activities and or palpation. So starting off looking at range of motion, as mentioned earlier, when we look at the elbow, you have to look at the movements of elbow flexion and extension, but we need to consider the impact of the radioulnar joint. So we will look at pronation and supination, and then often we will combine these movements. So look at flexion with the hand supinated versus flexion with the hand pronated. It changes the mechanics of the elbow joint itself, and so consequently flexion with a supinated hand may not cause any symptoms, whereas flexion with a pronated hand may reproduce your pain. You go on to passive range of motion, overpressures, repeated and sustained movements as indicated. When we come to do the muscle test, again we do the same things. We must check the elbow flexors, extensors, but also the supinators and pronators. It's also worth noting at this point that the finger and wrist extensors have their origin above the line of the elbow joint itself. So the common flex origin or common extensor origin can often get irritated. So it's important to check the integrity of the finger and wrist flexors and extensors. So get individuals to, for example, do gripping. When we come to to do length tests, check the length of any multi-articular muscles. So biceps is a biarticular muscle. You must check the length of that. The forearm or finger and wrist flexors and extensors are multi-articular muscles. You must check the length of those. Make sure that they're not tight. When it comes to the special tests, there aren't many special tests to do at the elbow. Probably a couple of the most important ones are the valgus and varus stress tests, as can be observed here. They are there to assess the integrity of the collateral ligaments of the elbow, which are fairly significant stabilizers of the elbow joint themselves. So when we do a valgus stress test, it stresses the medial collateral ligament. A varus stress test stresses the lateral collateral ligament. There's a variation of these tests in which the individual may be moved from a flexed position, varus or valgus stress is applied, and then the elbow is moved towards extension. These are known as the elbow quadrants. Special test for tennis elbow. Well, for the tennis elbow, for lateral epicondylitis, there's a couple of tests. We ask the patient to have the elbow in extension, the forearm pronated, and the hand is closed into a fist. We then resist wrist extension. A positive sign is when the patient complains of their lateral elbow pain. This test is sometimes done just with the elbow in extension and asking the individual to grip. There is also a middle finger extension test in which the middle finger is held in extension whilst the elbow is also maintained in extension. This has the effect of loading up extensor carpi radialis brevis in particular, which is the commonest site of irritation or commonest site of injury in a tennis elbow type problem. In a golfer's elbows test, the patient again extends the elbow. This time the forearm is supinated and the wrist is extended passively and overpressed. The individual would complain of pain over their medial epicondyle. Again, this test can be replicated. Instead of doing a passive wrist extension, we can sometimes ask the patient just to grip on an extended elbow. Ulnar nerve entrapment, as it passes in its groove between the olecranon process and the medial epicondyle or medial condyle, is not uncommon, and we can perform a test called Tinel signs in which we tap along the course of the nerve. If there is pressure, if there's irritation of the ulnar nerve itself, the patient will often complain of pins and needles and tingling over the ulnar nerve distribution, so over the medial 1.5 digits and medial aspects of the hand. Again, as with any other joint, there's a whole series of functional tests that can be done. Reaching, putting your hand behind your back, reaching up, grip, power grips and pincer grips, and then placing the elbow into various functional positions. So weight bearing on all fours, for example, a horse stance. On completion of your assessment, you should have identified a problem list and started to implicate certain structures. In planning your treatment, you need to have clearly delineated goals, both in the short term and for the long term.